Hey everyone, Dr. Shahid here, and in this second video dedicated to dental trauma, we're going to go over everything you need to know about displacement injuries. Our previous video focused on the fracture type injuries we can see in dental trauma, and for this video, we'll cover 6 displacement injuries, starting with concussions. A concussion in dental terms refers to a scenario where there's no displacement of the tooth, and the tooth maintains normal mobility. The only clinical sign for a concussed tooth really is just sensitivity to percussion. Typically, teeth in this condition will still even respond to pulp testing. So think of a concussed tooth as a small bruise. It's not too serious, and so the treatment is simple as well. The first step is to obtain baseline vitality tests and radiographs. Then, an occlusal adjustment might be recommended to alleviate any undue pressure on the affected tooth. But to be honest guys, immediate treatment usually isn't necessary here. The key is to let the tooth rest. And so you can simply tell the patient to avoid the area when chewing and to come back for regular checkups to monitor the situation. And as for the pulpal outcome, the good news is that the blood supply to the pulp is likely to recover because it likely hasn't been damaged, which bodes well for the tooth's long-term health. Sublaxation, on the other hand, describes a condition where the tooth is loosened but not displaced from its original position. This can present with some bleeding around the gingival collar of the tooth due to the loosening, but it's usually pretty slight. As for the treatment, again, since there's no underlying issue here, the initial steps are the same as with the concussion. So you get baseline vitality tests and radiographs, and you perform an occlusal adjustment if necessary. Now, if the tooth is notably loose, we can splint it for a couple weeks just to stabilize it and allow the periodontium to tighten back up. And regarding the pulpal outcome, there's a reported pulpal necrosis rate of about 6% in cases with closed apices, which is pretty low, and the prognosis tends to be even more favorable for teeth with open apices. Alright, now trending towards some of the more serious displacement injuries, we have extrusive and lateral luxation. And extrusive luxation is exactly what it sounds like. The tooth is partially extruded from its socket, and clinically, the tooth will appear elongated. A lateral luxation injury, on the other hand, describes a situation where the crown is displaced palatally or lingually, with the root apex moving labially. Lateral luxations typically are accompanied by an alveolar fracture as seen in the illustration. As for the treatment, again, it starts with radiographs to assess the extent of displacement. The next step after that is to carefully reposition the tooth, following by applying a physiological splint for stabilization. Now, since lateral luxation injuries typically involve a fracture of the bony housing as well, you'll want to splint the tooth for a longer period of time. And depending on the situation, endodontic therapy may be necessary, especially for mature teeth. In cases with open apices, observation for revascularization is also an option. Finally, when considering the pulpal outcome for mature teeth with closed apices, extrusive luxations have a 65% rate of pulpal necrosis, while lateral luxation injuries show an even higher rate at 80%. So needless to say, these two displacement injuries are pretty serious and need to be handled correctly. But you guys know what's even worse than an extrusive luxation or lateral luxation? An intrusive luxation. These are characterized by the apical displacement of the tooth, where it's pushed deeper into the socket. The treatment for this condition varies depending on the tooth's maturity. Again, for immature teeth with open apices, the preferred strategy is to allow the tooth to re-erupt naturally, especially if the intrusion is less than 7 millimeters. If no eruption occurs after 3 to 4 weeks, then orthodontic repositioning should be initiated. Now, in contrast, mature teeth with closed apices may require orthodontic or even surgical repositioning if the intrusion is greater than 3 millimeters. In these cases, you can be pretty darn sure that endodontic treatment is gonna be needed as well to address any potential complications. So as you guys can see, it's a pretty involved injury, and the pulpal outcome is significant with a high rate of pulpal necrosis at 96%. That's pretty much a sure thing. Alright, next we have avulsion, which is pretty much the worst case scenario in dental injuries. It's when a tooth gets completely knocked out of its socket. It's also known as an Ellis Class 5 injury. Okay, so what's the main thing to do here? Well, we have to keep the tooth support system, the periodontal ligament, alive and well. The best move is to pop the tooth back into its place ASAP. Doing this right away is great for the PDL and helps avoid the tooth's roots getting messed up. But if you can't reimplant it on the spot, the clock starts ticking. The longer the tooth stays out, the lower the chances of it fitting back in well. If it's back in under 15 minutes, you've got a 90% success shot. If you wait 30 minutes and it drops to 50%, over an hour, it's less than a 10% chance of success. Now, if for whatever reason you can't reimplant, you need to store the tooth, but you gotta pick your solution wisely. Milk is gonna be your go-to, not only because it's readily available, but it's also the best storage media. Hank's balanced salt solution or saline can also work, but let's face it guys, most people don't have this stuff hanging around the house. Okay, what about saliva? Not the best, it can actually damage the tooth. And finally, water is a no-go since it can really hurt the tooth's chances of surviving. Okay, let's now talk about how to actually manage an avulsion from a clinical standpoint. And we'll begin with an avulsed tooth with an open apex. And our treatment approach really depends on how long the tooth has been outside of the mouth. If the tooth has been dry for less than 60 minutes and has been stored in a medium like milk or saline, the management involves a few careful steps. Firstly, it's crucial not to touch the root surface. You don't want to damage the PDL. And if the root appears to be visibly contaminated, it should be gently cleaned with a stream of saline. Optionally, you can immerse the tooth in a doxycycline solution, and this is beneficial, but most general dental offices don't stock this stuff regularly. Next, any coagulum in the socket should be removed with saline, followed by a thorough examination of the alveolar socket. After all of that, the tooth is then reimplanted slowly using slight digital pressure. To stabilize the tooth, a flexible splint can be used for about 2 weeks alongside systemic antibiotics like penicillin or doxycycline, dosed according to the patient's age and weight. It's also important to consult a physician for a possible tetanus booster depending on the nature of the injury, but that's non-tooth stuff, so leave it to the medical doctors. Last thing to note is that within 7 to 10 days post-reimplantation, endodontic treatment should be avoided. That's way too early to be doing any definitive treatment. But you certainly want to monitor for signs of revascularization. If signs of an infected pulp emerge, beginning the process of apexification is necessary because remember guys, these are teeth with open apices. So if vitality is lost, our treatment goal becomes to create that apical barrier with MTA or calcium hydroxide so that we can have something hard to obturate against when we do get to the root canal procedure. Now on the flip side, if the tooth has been dry for more than 60 minutes, nothing really changes. You want to do the exact same procedures as listed above, but with the additional removal of debris and necrotic periodontal ligament tissue. Okay, now let's consider the management of an avulsed tooth when we have a fully matured tooth. And I'm gonna sound like a broken record here since the management is very similar to that of an open apex tooth, but if the tooth has been dry for less than 60 minutes and stored in a special medium like milk or saline, the approach is very similar to what I just described. First, it's important to avoid handling the root surface, but it should be rinsed with saline, and any coagulum in the socket should be removed before reimplanting the tooth slowly. Once in place, the tooth is stabilized with a flexible splint for about 7 to 10 days or 2 weeks, and systemic antibiotics, such as penicillin or doxycycline, should be administered. You can again pass off the tetanus duties to the medical docs, and within 7 to 10 days post-reimplantation, endodontic treatment should be initiated. This is a major difference between the two conditions. If you remember, with the open apex tooth, we didn't want to initiate root canal therapy right away because teeth with open apices are so receptive to healing, and we want to give them all the time they need in order to heal. That's the power of youth. You get hurt, fall down, get bruised, and you bounce back like it's nothing. And then you grow up, you go to dental school, and as soon as you're nearing your 30s, it seems like even sleeping funny will cause you to be sore the next day. Anyways, you want to initiate root canal therapy earlier rather than later for teeth with closed apices. But if during your initial monitoring you notice any signs of resorption or if the treatment needs to be delayed for any reason, then a long-term calcium hydroxide treatment is advised before completing the root canal filling, which just means you perform the pulpectomy and fill the canal space with calcium hydroxide and monitor the situation. For cases where the tooth has been dry for more than 60 minutes, the procedure is again similar, but with the extra steps to address the external root surface. This includes removing debris and the necrotic periodontal ligament, followed by immersing the tooth in a 2% sodium fluoride solution with a pH of 5.5 for 20 minutes. Alright guys, I know that was a lot of stuff, but let's now reinforce everything we just learned with a couple of practice problems. Which is the most likely to cause pulp necrosis? Pause the video if you need, and the answer is C, intrusion. Remember what I said earlier in the video, guys. Intrusion injuries are the worst types of injuries you can have according to the statistics, which tell us that intrusion injuries have a 96% chance of devascularization and needing a root canal therapy later on, which is quite high. That's almost a sure thing. So for our second question, we have an 8-year-old male with the following chief complaint. I fell on my face and my tooth hurts. We have no background on our patient history, and current findings indicate a 1 mm intrusion injury of the upper left central incisor. So the question reads, what is the treatment of choice? Pause the video at this point if you need. And the answer is A, allow the tooth to re-erupt. So the key here, guys, is the patient's age. They are 8 years old, which means that it's very likely that their left central incisor is not fully formed yet. It has an open apex. And in these situations, the protocol is to allow the tooth to re-erupt naturally because of the high likelihood of the tooth healing by itself. Alright guys, that's it for this video. Thanks for watching. See you next time.